Good to see an audience like this here. Nice turnout for some new technology. I'm not going to read the slide title here of this talk because it'll take about 20 minutes. As you can see, it's quite long. I do have a financial interest in this. I'm a consultant and I also have an equity share in Excellence. And this is really Pavel's work that I'm talking about here. This was the study that was done to get the CE mark. And we already know about the characteristics of the laser. We know that it has an optimized wavelength, which has been specifically chosen by David Mordaunt to go with the trypan blue stain capsule, so you get the maximum efficiency at the point of lasing. We've seen how small it is. The contact lens is customized for its use. And also, the other thing which hasn't really been emphasized is that this device has a patient fixation device on it. So it's a bit like on an excimer laser when you're doing LASIK. Patient can actually fixate, so you can get the visual axis that way if you want to. And there is a laser focusing mechanism that you've already seen. This is the device again. And you can see the console there down at the bottom right. It's really very small, and you can just dial in whatever number you want in order to get the capsulotomy size that you prefer. The purpose of this study was to assess the efficacy and the safety of this new laser for the creation of anterior capsulotomies during cataract surgery and to prove non-inferiority when compared to manual capsulotomy. It was designed as an open, controlled, prospective, multi-surgeon, single-center investigation. And what we wanted to do was to get patients that fulfilled the relevant entry criteria preoperatively. They would always have a full ocular examination, and then they were given informed consent. Surgery visit was done within 30 days of this pre-assessment, and the patients were divided between selective laser capsulotomy or CCC, continuous curvilinear capsulorhexis, which was performed at the time of cataract surgery. All the cases were recorded, and the images were used for measurements of size, circularity, and centration. There were 2 post-operative visits scheduled, one at 1 day and the other at 1 month, and the measurements were then all repeated. An external research organization monitored the whole thing. They looked at the 100% of the source data, and they verified that this happened on enrolled patients rather than anything else. There were certain study endpoints. The primary endpoint, as I say, was firstly to get accuracy with the diameter of the capsulotomy, to measure this at the capsular plane using an intraocular ruler for the capsulotomy disc once it had been removed and prior to phacoemulsification. And this was best done from an analysis of video recordings. And this is how you can see, you've already seen some pictures of this from Pavel. There were secondary endpoints, though, to do with safety, and this was about adverse events. And in serious adverse events, these had to be less than 5%, which might involve anterior capsular tears and other events of that sort. And in fact, we looked at these both intraoperatively, 1 week and 1 month. There were also some exploratory endpoints. We wanted to look and see what the circularity of the capsulotomy was like, what the centration was like relative to the dilated pupil and or the visual axis, and also the surgical efficacy of the new formulation of trypan blue, which had been developed specifically to use with this laser for the staining of the anterior capsule. And all of these measurable parameters were assessed by independent reviewers, and their analysis of these measurements from viewing of the video recordings was what was used in the analysis of the study. This is an intermittent cataract of Pavel operating. This was prior to using no air bubble. And after the capsule was stained, you can see the intense staining here. So this is a white cataract. Everything is in place, and again, we've got a nice capsulotomy, no hint of an Argentinian flag sign or any kind of tear out because of the way that the capsulotomy is formed and the speed at which it happens. What sort of results did we get? Well, according to the statisticians, we needed 55 patients in each arm. In fact, there were more than that. In the SLC group, there were 63 and 62 in the CCC group, and they were remarkably homogeneous across age and also the degree of cataract, grade 1, 2, or 3. So this gave us great confidence that they were going to have very good homogeneous results here. As far as the results of efficacy were concerned, if we looked at the primary endpoint of capsulotomy precision, you'll see that in all of these, sizing accuracy, circularity, and centration, CAPSULaser was very significantly better than manual capsulotomy, which is what you would expect, given that this is a precision device. As far as the secondary endpoints were concerned, there were no adverse events in either arm of the study. And we also observed that the capsulotomies made with the CAPSULaser were 100% free-floating, and also they had 100% 360-degree IOL coverage, which is important, as we know, in terms of PCO longer term down the track. Here we can see some of the examples. These are typical CAPSULaser patients, and these are the sort of views that the observers were assessing with the device to do the measurements. And you can see these are all covering fully the intraocular lens. What's interesting is that the mean results didn't look that different between the laser capsulotomy and the manual. I mean, that is probably an example of what a good surgeon that Pavel is. But actually, when you start to break it down and you look at more individual groupings, you'll find that 86% of the laser group were within 0.1 of a millimeter of the 5 millimeter, compared to 44% of the manual group. And that, again, was statistically significant. If you look at the frequency plot histogram, again, you can see that the red lines are the CAPSULaser, the blue lines are the manual capsulotomy, and the blue lines stretch out in a much less organized and close grouping compared with the laser capsulotomy. The same thing is true if you look at circularity. Here we can see one of the extreme examples of a capsulotomy in the CCC group that was off the intraocular lens. In fact, 91% of the patients in the capsulotomy group done with CCC were on the lens, whereas 100% were there with the laser. And if you compare with the literature, this actually is pretty good, because in the literature, 72% are only fully covered by, the lens is fully covered if you do it manually. With the femto, it's about 89%, although I think some studies indicate that might be rather better. What we also did was to compare, by way of a meta-analysis, CAPSULaser, FLACS, and CCC for sizing, circularity, and centration. And this is from many papers in the literature. I think we took 15 papers or something like that. And you can see quite clearly that the CAPSULaser is way over to the left, indicating much better predictability and grouping in that technology compared with femtosecond cataract or manual. Manual you'd expect, femto we thought we might have been a bit closer. So in conclusion, this clinical study has established that the selective laser, CAPSULaser, is safe, efficacious when used with trypan blue for the creation of anterior capsulotomies. There were no cataract surgery adverse events during the study, and all the laser capsulotomies were free-floating. The accuracy of the capsulotomy diameter and circularity was statistically superior for the selective laser group when compared with the gold standard, which is the manual CCC, which is the control group. And the new formulation of trypan blue had enhanced staining of the capsule and was safe when used with this laser. The SLC results were superior when compared in the meta-analysis to both FLACS and CCC. So the added accuracy of sizing, circularity, and centration may be useful with a new generation of capsulotomy captured and centered intraocular lenses. And there are two lenses out there now from two companies that are attempting to use the capsulotomy to make sure the lenses stay where you put them. So thank you very much for your attention.